Hi, I'm Chuck Stover, Director of Bethel Park Recreation, and your host for the Live Well Bethel Park Speaker Series, where we invite knowledgeable and engaging guests to share information on health-related topics that are important to you. Today, we will be discussing dementia with Dr. Tim Campbell and Silver Sneakers classes with instructor Renee Bishop. So stay tuned, Bethel Park, as we explore how you and your family can live well. Our primary presenter today is Dr. Tim Campbell, an internal medicine and palliative care physician with 4 decades of primary care and end-of-life care. He has spoken at the Alzheimer's Association conference on many different types of dementia.
All right, we are gonna talk about the patient with dementia. I like to start the talk with a quote. And on the screen you can see there's this one quote from Mahatma Gandhi that I always love, and it says, live as if you were to die tomorrow. Learn as if you were to live forever. You know, because we should all be lifetime learners, but you know, the life is an important part of that. Interesting phenomena is how we die. Many people think that we often will die in a big event like acute heart attack or big stroke or maybe like a motor vehicle accident, things along those lines. But very few of us actually die that way. Most of us have like a slow dwindling, but the sudden deaths draw a lot of the attention. They offer no anticipation for preparation, no opportunities for closure, so to speak. And so the sudden deaths have like a lot more emotional impact. But 10% of Americans die quickly, 90% of us dwindle. Well, I had kind of dwindled down, a prolonged, illness, typically. And this next slide shows like a lot of the trajectories. Like a sudden death would be like a heart attack or a stroke. A terminal illness would be an illness like cancer, where people will be doing fairly well for a while and then they'll have a pretty rapid drop off. And then if you have something like organ failure, like congestive heart failure or kidney failure, liver failure, you might have periods where you're doing pretty good and then you get worse. Then you get better again a little bit and then you keep declining. But the trend is still down overall. And then there's the last pattern is like a trajectory of death that people have is like the dwindles, where you start with a low level of functioning like dementias, and then you just kind of get lower and lower as time goes on until you peter out and die. And that's the trajectory of most dementias. And a lot of people, don't really understand how pervasive dementia really is in our society. A lot of folks go instantly, boom, to Alzheimer's disease, thinking that's the dementia of all. And actually, there are hundreds of different things that can cause dementia. Hundreds of things. We're going to talk about 10 today. But with our aging population, the silver tsunami, as we get a little bit older, America, our changing demographics.
Doc, is that the baby boomers you're referring to?
The baby boomers, the silver tsunami, as we get more silver hair as time goes on. As we treat chronic illnesses, like for instance, in 1900, the life expectancy was about 40 years of age. Today, we expect folks mostly to live into their 80s, for most men and women. And there's some evidence to suggest also that a child born today, right now, 2022, will probably live to be about 100 years of age on average. 100 years of age. It's because we're getting so much better treating a lot of these illnesses. So we're going to see a tremendous shift of care, a tremendous shift in our healthcare energies and expenditures into these into dementia as we get older.
A real quick question, talking about life expectancy getting longer.
Mm-hmm.
Is it due to like the wellness we're starting younger?
In large part, a lot of folks said between 1900 and 1940. Our life expectancy went from 40 to 60 years of age, right before we got into World War II. Why do you think that is?
Because of the sewer system.
Bingo, spot on, indoor plumbing.
I remembered from last year.
Exactly right. Everybody attributes to antibiotics, but they didn't really come until 1939, 1940, after that, when we started getting a lot more of the antibiotics. So this first slide, the woman that you see there, it's interesting. She's Auguste Dieter. She's the first patient who was diagnosed with Alzheimer's disease by Aloysius Alzheimer. So let's go on a little bit more and look at some of the statistics for the patient. 1 in 3 seniors in America will die with a diagnosis of dementia. 1 in 3 seniors will die with a diagnosis of dementia. It might not be to the point where they're really compromised very much with it, but they will have it. It's the 6th leading cause of death in the United States right now. That's 5.3 million Americans that have the disease now. And what's kind of interesting, more than 200,000 of those Americans are less than 65 years of age. I have diagnosed dementia on a 43-year-old.
While we're on this, do we find it starting earlier now, or?
Maybe, no, we're living longer. So we're seeing a lot more people with it, but we're getting better with our diagnosis. We have better tools to go ahead and diagnose it now than we had previously. Still, it's a clinical diagnosis for the most part. It's not like I can order a blood test to show you have Alzheimer's disease. Even CAT scans and MRIs give us some non-specific information, but there are some new PET scans that are coming out, different types of brain scans and brain imaging, which will make the diagnosis a little bit easier. But, you know, it affects the patient, but it also profoundly affects the caregiver. And again, most of us will be touched at one time in our life with this. 60% of people report, or 60% report a higher emotional toll for the caregiver and a lot of stress for taking care of their loved one. And a lot of it is kind of can be frustrating, could after a while. You know, like the repeated questions or some behaviors that might show up. In fact, 40% of the caregivers report depression. That they have they're depressed themselves.
I believe it.
They say it provides almost 18 billion unpaid hours in far as taking care of the patient, the caregivers taking care of the patient with dementia. And what's kind of interesting is the caregivers, 2/3 of them are women. 1/3 of the caregivers are over age 65 themselves. So you can imagine if a woman is in her 90s and she has dementia, chances are her kids taking care of her are
over 65?
Over 65 as well, exactly.
And that takes a toll on their health too.
It does. So it affects the patient, it affects the caregiver, it affects the nation. Healthcare costs are now $226 billion, that's with a B, $billion in taking care of the dementia patients. And if you have a senior with dementia versus a senior who doesn't, the healthcare costs are 3 times more taking care of a patient with dementia.
Wow.
That's 1 in 5 Medicare dollars. 1 in 5 Medicare dollars is spent on patients with dementia. So, you know, we're just seeing the tip of the iceberg. What's to be projected? The number is going to be tripled to 13 million by 2050. You know, 13 million people with it. Quadruple national costs to $1.1 trillion. $1.1 trillion. And that, at that time, the expenditures will probably be about 1 in 3 Medicare dollars will be spent on patients with dementia. So, you know, anybody thinks that you know, they're not going to be affected with it, it's huge. It's going to impact all of us across the board, patients, caregivers, and us as a nation. But you know, with all these challenges, it creates a lot of opportunities of things we can do, things that we could do to help out the patients.
Given we're post-pandemic now, and the healthcare people are just kind of getting back to some normalcy. So this is going to keep that stress level for everybody up.
Well, it's an issue that's not going to go away as we get older, as we live. We have more seniors, as we talked about. You know, it seems to be associated with that. So, you know, you can look and say, gee, Tim, that's pretty depressing. I'm just thinking I can go home and get a quart of Ben & Jerry's ice cream and like, put it between my legs and climb into a cupboard and quiet, you know, and like not talk to anybody. But there's a lot of things we can do. There's a lot of hope. There's new research that's taking place, new medications that are pipeline medications. I did a search on this as of the day before yesterday. 149 pipeline drugs are in play for treating Alzheimer's disease. Will most of those come to market? No, probably not. But there's a lot of other things coming down the pike. And we have a better understanding of the disease. We have better treatments for the disease. So there's always hope. There's always hope.
So with the new PET scans that are out, will that help diagnose what type of dementia it is better?
It'll help out a lot more.
Well, that would be a big help.
Yep. So when you use the term dementia, it's really a non-specific term. You know, it's kind of like a global, all-arching thing. So dementia, it's like a decline in memory. It's a decline in thinking skills, and it's usually enough to when it starts to impair a person's activities of daily living. You know, that's when we do it. This slide, by the way, the gentleman you see there, that's Aloysius Alzheimer. That is the Dr. Alzheimer. And I mean, you're going to see all these folks. They're old white guys who have beards. You know, so as we go through a lot of the folks, the neurologists who made a lot of these diagnoses, pretty cool. But for dementia, you have to have really two of the criteria. One of the criteria is a defect in memory. A defect in the second would be like a problems with communication or language, the ability to focus or to pay attention, impairment with reasoning or judgment, or problems with visual perceptions, like people seeing things or misinterpreting them. So for the cognitive issues, the memory issues, it's usually a problem with like just generally tends to be short-term memory, can be long-term memory as well, but the problems with recalling things and processing that information. And then the other symptoms that folks that have dementia were called neuropsych dementia. So there are a lot of the behaviors, mood changes, disruptive behavior, dangerous behaviors, they could affect it. So if we talk about cognitive issues first, it's usually confusion, memory impairment. It might be problems processing information, like being able to like manage a checkbook, or maybe able to plan a calendar out, things along those lines.
I got a question with dementia. Will it bring back different parts of memories that people, the older generation didn't talk about a lot of things, their childhood, the wars, and all of a sudden you're talking to an older relative and it's like, you look, I'm like, where'd that come from?
Well, with many of the dementias, people will have short-term memory loss. They cannot make new memories. They cannot make new memories. But their old memories may be intact. They might be able to recall quite well their address or the street growing up, for instance. So what do? They tend to rely more upon those memories. Makes them a little more comfortable. Now the neuropsych symptoms, those are the ones that are pretty more distressing for a lot of folks. That could be how it affects depression, anxiety. People might become withdrawn. Now my father-in-law, interestingly, he became more animated, more outgoing, as he had more problems going on. Then the behavioral issues associated with that can be really distressing. That could be like the repetition. When are we having breakfast? Where are we going? Where are we going? Where are we going? Have you seen my socks? Have you seen my socks? Things like that over and over again. Some people become very oppositional. They'll resist care. Like, I'd like you to get bathed today. No, I'm not going to. They might become very contrary and cantankerous along those lines. Agitation, restlessness. I see some folks who do a lot of pacing, or they'll stand up and sit down over and over again. Some folks may hoard as a symptom of dementia. Not always, but they may. Some folks may be very sexually inappropriate. For instance, in the front part of your brains, we have what's called the frontal lobes. That controls a lot of your executive functioning. If you have strokes in that area or a dementia that affects that part of the brain, it controls like a lot of the behaviors. So people might act on impulses that normally wouldn't. Sometimes it can be very embarrassing for family members as well as for the patient. And then sleep disturbance is very common. Aggressiveness, some people become really kind of like violent. We hear a lot about wandering, where people get up and wander and get lost. Or they may have hallucinations. They may see things that aren't there, hear things that aren't there. So a lot of these are the symptoms that could be really distressing for a lot of family. And it's those neuropsych symptoms that seem to, as the cognitive disorder changes get worse, the neuropsych symptoms get worse. And the neuropsych symptoms are a bad prognostic indicator, which means if you're seeing a lot of neuropsych symptoms, chances are that dementia is going to continue to progress. We'll see a lot of changes with the Alzheimer's, the dementia. In any event, 90% of the dementias will have some sort of neuropsych behaviors associated with it. Some sort of distressing things. It might be distressing not only to the family, but particularly to the patient as well. And because when folks have these neuropsych symptoms, it could increase the cost of the patient anywhere from 25 to 35%. Just because you have to control the price. So like mom takes a vase and throws it through a picture window, it's time we have to call the police, or we have to go ahead and call an ambulance, take her to the hospital, Those increase the cost tremendously, with dealing with that. So the patient suffers with the neuropsych symptoms, but so does the family.
Yeah,
And
I've seen that in relatives. I had one relative towards the end, they couldn't even speak. It was just like sounds. Mm-hmm. And you could see that person getting frustrated, and you could see the caregivers like getting sad, depressed.
Right. Sure, how could it not affect us, And then when you have to deal with it 24/7, there's no end game with this, for a lot of folks. So it increases caregiver issues, it increases societal issues, tremendously increases the cost of health care. And it's the largest reason for emergency room visits to the, for a patient with dementia. Some sort of crisis, a neuropsych symptom that pushes them into it. They get out, they wander, they break something, throw a water pitcher, things like that. So here's a list of the major dementias. These, again, the major ones. These are the top 10. And actually, probably the top 4 or 5 are the ones that really cover maybe like 95% of all dementias. So we're going to talk about them in detail. But first, I do want to talk about Alzheimer's disease. And as I shared, this is a picture of Dr. Aloysius Alzheimer. Very distinguished man. I love the beard and the little glasses, fit over his nose. But Alzheimer's is the most common type of dementia. It accounts for about 60 to 70% of cases. And the greatest known risk factor is aging. And most of the people with Alzheimer's are greater than 65 years of age. And as I mentioned before, even with up to 200,000 Americans can be diagnosed with Alzheimer's quite early. 6th leading cause of death in the United States. And when you're diagnosed with Alzheimer's, the average life expectancy is about 8 years from the onset of symptoms. But the kicker is, even though you develop, the life expectancy is only 8 years, people have started having changes in their brain 10, 20 years ahead of time. And that's where powerful a lot of these the scans that are coming out are going to be so helpful, helping us diagnose this and treat it earlier. In Alzheimer's, there's a very classic change that occurs. There's what are called beta amyloid plaque. Amyloid is a substance it's produced by our body, but for some reason we start depositing large amounts of it in various tissues of our body, the brain being one of them. And then they get these little twisted tangles also of protein. They're called tau proteins, and they can deposit also in the brain. And as these products are deposited in the brain, they kill a lot of the nerve tissue. And that's what happens. So these amyloid plaques, the tau tangles, they're the primary suspects in really causing the damage of the brain in the first place. So this picture, this shows some of the beta amyloid plaques. You can see like the little brownish areas that they're associated with there. Again, that's just this amyloid that's deposited within the brain. And then see the other spikes alongside those? Those are tau tangles. And those are also deposited in the brain. As you can imagine, as this material is deposited in the brain, it damages the nerves. The nerves can't function properly. So some of the thoughts are, well, can we get rid of that? Can we get rid of that plaque? Can we get rid of those tau tangles? That's where a lot of cool research is being done right now. Or can we prevent that from being deposited in the first place? And there's a lot of good targets there. We'll talk about in a bit as well. So early time and early Alzheimer's is said it could start 10, 20 years even before people develop symptoms. Usually you'll see some amyloid deposits in the bottom of the brain. As the disease progresses, it tends to extend forward and then cover the entire aspects of the brain, towards late disease. And as it occurs, as this material is deposited, it kills the brain. You actually see loss of the neurons within the brain. And if you look at a CAT scan or an MRI or other brain imaging, you can actually see the brain kind of crenate, shrink a little bit. It gets smaller, and it was replaced by a lot of the cerebrospinal fluid around the brain. Does it always matter that way? No, because I've seen patients with horrible changes in the brain on the CAT scan or an MRI, and that yet they're perfectly functional. On the flip side, I've seen brains that look like they're very healthy, but people have severe dementias. So, but as a general rule, as this brain gets damaged, we'll see a little bit of shrinkage of that tissue. So with Alzheimer's, a lot of people primarily have difficulties with recent memories. They can't make new memories. You introduce yourself to them, 5 minutes later, they don't have a clue who you are. You ask them to remember 3 items, they can't recall any of them, within a minute or 2 minutes. So again, it tends to be more short term. But as you said earlier, some folks may have well-preserved long-term memory. That may be intact. Early on, some of the neuropsych symptoms, people might be a little bit lethargic, listless. They may be apathetic. They might even have some depression symptoms. Later on, they often develop problems with impaired communication. They'll have poor judgment. They'll have a lot more confusion. They might have a lot worse of the behavioral changes that we talked about as well. And then slowly as the disease progresses, more and more of the symptoms will often emerge. So next, let's jump forward and let's look at the vascular dementias. As said, the Alzheimer's, 60 to 80% of folks will have dementia, but very few dementias are pure one or another. There might be overlap between a lot of different types of dementias. Vascular dementia implies exactly what it says. When I was in residency, we used to call this MID, multi-infarct dementia. So if a person has like a big stroke in one part of their brain, they might have like weakness, for instance, on one part of their body, or may not be able to speak. It's a sudden, big event. With multi-infarct dementia, instead of like a rifle shot, it's like a shotgun. It's got scattered apart. You get all these little teeny tiny lacunar infarcts, we call them, like tiny infarcts throughout the brain. For instance, Alzheimer's, atrial fibrillation, when people have the irregular heartbeats, they may form clots in the heart. Or if they've got irregular heart valves, they may form clots on the valve that break loose and travel up to the brain, and they'll have these little teeny tiny strokes throughout the brain. So that's causes vascular cognitive impairment. The brain is probably one of the biggest areas of the body that require the most nutrition, the most oxygen. Within a couple minutes of you not getting blood flow to the brain, you'll start having damage to it. So this probably accounts for 10-20% of the cases with dementia, but the brain is really vulnerable because it requires such a rich oxygen supply, a rich blood supply. So if those are compromised, then you can imagine if you pick off all these little teeny tiny parts of the brain, you get some loss in cognitive function of vascular dementia. If it occurs like suddenly, like after a big stroke, we can often pin that down, but sometimes it's kind of hard to pick up little teeny tiny strokes that may occur over weeks or months or, years in a lot of cases. And it's the cumulative damage that often causes problems with the losses here. People with vascular dementias, they might have impaired judgment. They might have difficulty making decisions. They may present very much like a patient with Alzheimer's disease. They may have problems planning or organizing events. Early on, it may be less prominent than Alzheimer's, like subtle little changes, but it depends on what parts of the brain were affected by the little teeny tiny strokes, the number of strokes that occurred, how many of them occurred. So that impacts a lot of it and how the individual will present. Next, we want to talk about dementia with Lewy body. Have you ever heard about this one? A lot of folks haven't. Yeah, a lot of folks haven't. Again, this probably accounts for maybe 15-20% of the dementias. And with Lewy body dementia, it's often associated with like Parkinsonian or Parkinson's disease.
Yeah.
Right. And what they get is they get a deposit in the brain of a protein called alpha-synuclein. And on this picture you can see here, it kind of looks like a little pink area. But we don't even know what alpha-synuclein does. We don't really have an understanding, but there seems to be more and more of these deposits within the brain. And as they accumulate, people get worse. But it doesn't have to be pure. One type of dementia. A lot of folks can have mixed dementias. This is a picture of Dr. Lewy, Friedrich Heinrich Lewy. He's the only person I have that doesn't have a beard today or a mustache. But Lewy bodies can be found in other types of dementias. Like we could see it in Alzheimer's disease, we could see it in Parkinson's dementias. The presentation, often folks will have like Parkinsonian symptoms. They might be a little more rigid. Bradykinesia, which means that they might like move very, very slowly, or gait instability, like they'll be unstable. Or if you see them, they might have to rock a number of times before they get up, to get movement initiated.
Do you get tremors in the hands and that?
Yeah, we can certainly see that, the 2 to 3 hertz resting tremors that a lot of people with Parkinson's have. But curiously, a lot of the folks with Lewy body dementia, even though it seems to be associated with Parkinson's, may not have the tremor. They may just present with more of the rigidity. Tremor might occur quite late in these patients, but that's a good question. In Lewy body dementia, the dementia will show up, usually primarily first, and then the dementia shows up, and then the neurological symptoms will develop within a year. With Parkinson's disease, they'll usually develop the problems with the motor problems, the rigidity, the spasticity, the tremor, and then the dementia may show up like 10 to 15 years later on. So usually with the Lewy body disease, it's a much closer, compressed course of events. The memory loss and thinking problems are kind of similar to Alzheimer's disease. Often they'll get sleep disturbances. In fact, they may act out dreams, sometimes violently. There have been reports of people actually killing a spouse, with their dreams with the Lewy body dementia, thinking that they're harming them in bed. It was very, it can be very disturbing. They can have also very well-formed visual hallucinations. And curiously, what they'll see is they tend to see more children and animals. Generally, they're not threatening. They don't really scare a person too much, but they'll say, oh yeah, the fella came out. I had a patient tell me this. Yeah, I saw the children come out of the television. They were playing with the dog, and then they went back in again. You know, so they may have those kind of visual hallucinations or may have a lot of delusional thinking.
Wow.
So the confusion, the alertness, it varies significantly from one day to another. They might do well for a day and then not do so well for a couple of days, and then may do well for a day. There's a lot of variability in how they present. So again, that's Lewy body dementia. And then probably the one I did want to talk about too is the mixed dementias. As I said, it's not pure. Not everybody has one type of dementia. Some folks may have a mixture of different types. Alzheimer's, as I said, 60 to 80%. The vascular dementias could be around 20, 25%. You know, Lewy body could be 20, 25% in some folks as well. But these mixed dementias are probably more common than we thought. And still, but Alzheimer's would probably be predominant. Lewy body quite predominant, and vascular dementias is the top three. With the mixed dementias, that rounds out the top four, you know, across the board. It's kind of scary, Chuck. It can be, you know.
Well, we never hear about the Lewy bodies or anything else. It's always Alzheimer's, Alzheimer's, Alzheimer's.
Yeah, and for good reason, because again, that's the vast majority of the type of dementias that are out there.
Yeah, but it's nice to have this other information so you can get better treatment.
As you can understand too, with the mixed dementias, how they present really depends on what the primarily underlying dementia is, how extensive the disease is. You know, if they present mostly with vascular and then have some Alzheimer's components or Lewy body, they may present with different symptoms across the board. But the symptoms kind of suggest to us what kind of dementia does it matter, and why is it important? Because we may treat them differently. You know, we have some medications that perhaps, for instance, works better in Alzheimer's disease or primary degenerative dementia, Alzheimer's type of dementia, versus a vascular dementia. A vascular dementia, if they're forming blood clots, I might want to treat them with a blood thinner. With a vascular dementia, an Alzheimer's type of dementia, I might want to give them something that raises the chemicals in the brain a little bit, the neurotransmitters in the brain. So let's talk about Parkinson's-related dementias next. Parkinson's disease will affect 2% of everybody over age 65. It's fairly common. 1 million Americans have Parkinson's disease. 1 million Americans. And 50 to 80% of those patients will eventually develop a Parkinson's dementia, you know, provided they live long enough. And how it progresses could look like the Lewy body dementia, or it could look like an Alzheimer's type of dementia.
I think of Parkinson's, I immediately think of Michael J. Fox.
Exactly. And interestingly, with the dementias associated with it, curiously, if you treat the underlying disease, if you treat the Parkinson's, people may have improvement with the cognition with it as well. So if I have, or a lot of the neuropsych symptoms, so if I have a patient who is like Parkinson's dementia and he's not on medication, I may want to try to optimize the medications first as much as we possibly can. We have a lot of wonderful medicines to treat dementias, tremendous medication, and to treat Parkinson's. But it's growing. We're having a little bit more tools in our toolbox as time goes on. So next I want to talk about frontal temporal dementias. This is kind of scary. Again, the frontal lobes, to review your anatomy, is the part up here in the front of the brain. That's where a lot of our executive functioning is, our higher processing. And they used to call this Pick's disease, or behavioral variant frontal temporal dementia, or also called a primary progressive dementia, which means it occurs, again, principally in the frontal lobes. Some people have a lot more behaviors with it than you'd expect otherwise. Some people might have more problems with being able to put words together, to make speech. And again, if you look in the brain, there's a lot of these Tau tangles that we talked about earlier, those proteins that are deposited in the brain, but they have another protein in the brain called TDP-43. And we're usually here in the frontal and the temporal lobes that's deposited. It's characterized primarily by a deterioration of functioning. Personality's lost. Again, your personality, your executive functioning is up here in the front part of the brain. And the temporal lobes are where we have a lot of or capabilities for like having speech, being able to talk properly, understand things. 50 to 60,000 Americans will be diagnosed with this, but here's what's scary. Between the ages of 45 and 65 typically, I'll diagnose this dementia on younger folks. So it's devastating.
Is there a common theme with the younger folks?
No, we really don't know.
Thinking, And go back to concussions because that's
We'll talk about that later. Traumatic brain injury (TBI) is a big cause of dementias. But no, a lot of these folks, if you extrapolate out all the other risk factors across the board, they seem to have a higher incidence of just have this developing right out of the blue. We don't quite understand the risk factors for this yet, but tragic. And I mentioned earlier, I diagnosed this on 43-year-old. Tremendous. Within 4 years, she was dead. Wow. From dementia. So frontal temporal dementia. This is a picture of Dr. Pick. Again, nice mustache, nice beard, as you can see across the board. And these are the Pick bodies in the frontal lobes of the brain. Again, these are those TDP43 proteins and the tau tangles that are deposited in the brain. Now, a lot of folks will say, well, can't you just do a biopsy of the brain and make the diagnosis early on? Yeah, but we don't want people to lose brain tissue. This is usually a post-mortem diagnosis. Again, we're getting better on our imaging to be able to kind of tease out the different types of dementias across the board. Those are the tau tangles. And then again, for frontal temporal, there's a lot of different ways of looking at this, but primarily it's the behavioral variant or the primary progressive aphasia. Who was diagnosed? Wasn't Bruce Willis recently diagnosed with a primary progressive aphasia?
Alopecia?
Pardon me?
What was it?
I thought it was that, but in any event, he no longer is able to make moves. He can't speak like he used to speak. And again, that's the nature of the illness. All right, let's talk about the next one called Creutzfeldt-Jakob disease. This is a much more rare disease. You've heard of mad cow disease?
Yeah.
All right. Mad cow disease is actually caused by what's called a prion, a protein that's deposited in the brain, and it causes more proteins to take the same shape that it does, an abnormal shape. And as these proteins are deposited in the brain, it gets worse and worse. And in cattle, if we ingest that protein, especially like steak tartare, raw steak, things like that, I just don't know why people like to do that, but if they do, you're more apt to have it. Now, thankfully, we don't see much mad cow in the United States, but terrible outbreak in England a number of years ago.
Yeah, I remember that.
Yeah. It's rare. We're talking about 1 in a million people worldwide, but as these prion proteins fold into this abnormal three-dimensional shape, they will take other proteins and cause them to form into the abnormal shape. It keeps depositing in the brain, and that's what happens with this disease. They'll often show up with depression. They might be agitated, but more often they'll tend to be more apathetic. They'll have a lot of mood swings across the board. We'll see a rapid progression in this illness as well. A lot more confusion, a lot of disorientation. Again, problems with memory, thinking, planning, judgment. They'll often develop problems walking, and they might start to develop a lot of stiffness and rigidity in their muscles. They might become a little bit twitchy and jerky at times with a lot of their movements. So next we're going to talk about normal pressure hydrocephalus. I diagnose this probably about 3-4 times a year to level with you across the board. And it's when there's an increase in the cerebral the fluid in the brain. Our brain sits within like the skull, and around that is a lot of fluid, cerebrospinal fluid. Well, if the fluid can't be absorbed down like in the spinal cord and some other parts of the brain, it tends to increase a little bit more, that pressure. And they call it normal pressure because when I do a spinal tap on these people and I measure the pressure of their spinal fluid, it's normal. So you'd expect with all this more water in the brain that we'd see higher problems. So as the CSF, the cerebrospinal fluid, disrupts and damages the brain tissue around as it kind of compresses it, pushes it in. And this occurs primarily patients, I typically diagnose it in their 60s or 70s. I've diagnosed it in folks in their 80s and 90s as well. I think I had one patient diagnosed in his 50s with it. But the classic triad, they have 3 different symptoms. One, they have difficulty walking. It's almost like they're walking on a boat. We used to call it the drunken sailor.
Noah's Ark.
Noah's Ark, exactly. Kenny would. They tend to work with their legs bent forward. They keep their feet wide apart. Trying to maintain themselves, and they have a shuffling gait. So that's the problem with the walking. Then they have their decline in their thinking skills too. So they have problems like with memory, recall, difficulty planning, making decisions. We might see personality changes as well. So that's the second feature of it. And the third is to start losing control of their bowel and their bladder. So if I have a patient who presents to me with those 3 patients, one of the first things I want to do is do a CAT scan of their head, see if they've got this normal pressure hydrocephalus. Hydro means water, cephalus means brain, water in the brain. You see more water in the brain on the brain imaging. Next, let's talk about Huntington's disease. A tragic illness. We know it's caused by a single defect on one chromosome, chromosome number 4. And what this defect is dominant, which means if you had a parent who gave you the gene and another parent who didn't give you the gene, if you have one gene of this abnormal Huntington's gene, you're more apt to go ahead and develop the Alzheimer's disease. This is Dr. Huntington. Check it out. Nice beard. They all have beards. Don't know why.
That was the style back in the day.
Yeah, it was the style back in the day. But the onset, again, between ages 30 and 50. It's been diagnosed as young as 20. We've had patients diagnosed with Huntington's in their 80s. It's kind of unusual. But they'll often get these uncontrolled movements of the arms, the legs, the face. They call them choreiform movements, where it might see like a patient kind of do something like that. Those kind of slow movements that are kind of uncontrolled. They can't really control it too much. They'll often have a big decline in memory, concentration, the ability to plan and organize. And often, a lot of these folks, because it's autosomal dominant, they may have seen it happen in a parent or a relative because they're inheriting the gene for it. So it can cause a lot of depression, anxiety, anger, irritability. They may see a lot of OCD type of behaviors associated with it as well. Repetitive questions, repetitive behaviors. One of the biggest causes of Huntington's, death in Huntington's disease, suicide. Because people see what has happened to their loved one. They don't want that to happen to them. So important to tend to the patient as a whole.
Wow.
All right, the last of the 10 that I want to talk about too is Wernicke-Korsakoff syndrome. This is more dementias associated with alcohol. In particular, the deficit is if they have low levels, severe deficiency of vitamin B1, thiamine. And thiamine helps the brain produce energy. If it falls too low, the brain cells can't function properly and they may die. It can be associated most commonly with alcohol abuse, but we've seen it with HIV, AIDS. We've seen it with dialysis patients who may not be taking vitamin replacement.
Would there be any other drugs besides alcohol, like marijuana or anything like that can contribute?
Alcohol seems to be the primary one more than the others, but hey, they have seen it with other illnesses. A lot of other chronic conditions can do it. Poor nutrition. If a person's just not getting, say they're eating tea and toast, and that's it, nothing else. If they don't have fortified bread, they may not be able to get it. Interestingly, when bread is made in the United States, it requires to be fortified because it doesn't have a lot of the B vitamins in it. It doesn't have a lot of other vitamins in it. Certain cancers can do this as well, to boot. So this is a picture of Dr. Wernicke and Korsakoff. Great beards for both of them, as I shared. But Wernicke's encephalopathy. Encephalopathy means brain's not working very well. It's diseased. It's caused by, again, the thiamine deficiency. People have interesting 3 main symptoms. They'll have double vision. Like I'm seeing 2 of you. They'll have ataxia, the unsteady gait. They'll have the confusion also. So that is a triad of the things that they more commonly see across the board. Where, you don't get the double vision, for instance, when we talked about that normal pressure hydrocephalus. You'll get the confusion. You might get the unsteady gait, but they'll have problems, for instance, with normal pressure hydrocephalus with incontinence. With Wernicke's encephalopathy, you have more problems with vision. So often we'll get little clues from the history to be able to tell what's going on with the patient. Now, Korsakoff syndrome is he says all the stuff that Wernicke said, but there's a few other things. They can't make new memories. So they have what's called anterior grade amnesia. They have retrograde amnesia. They can't remember what happened in the past. They may have what's called aphasia. They just can't speak properly. They can't find the words out or get them out properly. Or if they have what's called apraxia, if you have them do an action, they can't necessarily do it. Like take this paper, fold it in half, put it on your head. They cannot do that. Or else they may have agnosia. You'll take, like, for instance, keys. You put them in your hand. What are these? And they'll say, they can't find the word for it. So that's agnosia. And again, they have a lot of problems also with this executive functioning. They can't plan, they can't reason, they can't problem solve, properly. So they have problems like learning new information. They have problems, memory problems can be quite striking, very, very striking. And they, like for instance, they may be able to tell you what they had for breakfast, or they may not be able to tell you what they did 2 minutes ago. And then interestingly, with Wernicke-Korsakoff, they may confabulate. What do you have for breakfast? Well, they may have had a bowl of cereal, but they said, oh, I had the best eggs, scrambled eggs with bacon, and I had a big glass of orange juice with it, and I had a Danish with it. They'll confabulate. They'll make up the history. It's not because they're purposely lying. They don't know. It's part of the nature of the illness. So, and then they may have the mixed features, the vision abnormalities we talked about, the ataxia, the confusion to boot. Now here's just a list of like some of the things. You mentioned traumatic brain injury, like post-concussive. That's huge, and that's cumulative too. We know that down the road. And if you've had a TBI once, if you had traumatic brain injury once, and you get brain injured again, it's a much, much higher chance.
With that, I think back to with the way you're defining concussions now, I think back to my youth, and I'm like, how many did I actually have? I mean,
hey,
if you've seen Stars, they say it's a concussion. I'm like,
I played football.
That was once a week, maybe in football.
Yep, gotcha. Regular basis.
Yeah.
There's a lot of things. Posterior cortical atrophy, medication induced. For instance, some of the medications could make a person seem like they're demented. The beta blockers. I'm on a beta blocker for high blood pressure. I've been on it for decades across the board. Great blood pressures with it, but in some people, it can impair their thinking a little bit. It might slow them down a little bit. Then there's something called a pseudo-dementia. This is probably one of the more common ones. Pseudo-dementia. Pseudo means it's not really dementia, but it could look like it. Depression. If a person is depressed, dysphoric, despondent, if they're anxious, they may act like a patient who's dementia. You treat the underlying dementia, and it gets better. In my practice, in the internal medicine literature, it suggests that I'll diagnose depression or anxiety on 100% of my patients at one time or another. The literature suggests that I will treat 20 to 25%. 1 in 4 to 1 in 5 people I will treat with depression. It's much more common than you'd ever imagine.
I think it was more common back when we were younger too, but they just didn't recognize it.
No, and that's right, or there was a stigma associated with it. Terrible.
There still was a stigma.
And there shouldn't be. If a person has pneumonia, what do? I treat them with an antibiotic. If a person has depression, I'll try to treat them cognitively without medications first, but if I don't have to, but if it's to a point, sure, I'll absolutely use medication. Why do we discern that as anything different as far as dementia? As illness? The other thing for systemic illnesses or conditions, there's a bazillion things here could do it. For instance, lupus can cause problems with the brain. Congestive heart failure can easily cause problems with it. So many infections can do it. Abscesses in the brain, infections, meningitis, viral bacterial meningitis. Oh my word, the list goes on for Lyme disease. I've diagnosed that probably once a year, Lyme dementia. Sexually transmitted diseases could affect the brain as well. Syphilis was horrible back in the day, a bazillion years ago.
Yeah.
But even diseases like herpes can affect the brain. So again, I could go on with a list. Low thyroid, if the salts are off in the blood, the kidney functions are off, the liver functions are off, it could affect thinking to some degree.
Wow.
So we really don't, I could spend here for a year just talking to you about each of those, but we don't have the time for that. But I just want to address there's a lot of different things.
That makes you realize how fine-tuned a machine the body is.
Bingo. So what do we do? How do we treat these? Again, it really depends on the type of dementia. Treatment should be directed not only at the cognitive losses, but certainly at the behavioral losses as well. But you know what? There's no free lunch, is there? All medicines have side effects, every single one. And you have to really direct your care based on the type of dementia and the symptoms that people are presenting with as well. Some people are rabidly anti-medication. I don't want to take any medications. It's not natural. Polio and cancer are natural, but we could still treat them. We could still do something about it. But I absolutely value the use of medications in the treatment of these illnesses if we do it properly, if we do it judiciously, very carefully. And a lot of folks like a lot of herbal medications, natural remedies medications. You kind of balance traditional versus alternative medicine for the treatment of the dementia patient. And I made this slide, I just pulled this up of some of the things I found on the internet, like marijuana to treat dementia, soy products, herbs and ginseng and coconut oil and infrared light on the brain. There's a lot of things that people push out there. Here's one. I love this one topic. Let me find it. 13 cures for dementia. Well, good luck with that. We don't have a cure for dementia. I could treat it, but I can't cure it. But there's a lot of garbage out there that people kind of get sucked into.
It's on the internet, it's true.
Sure, and like I said, if you have a picture of somebody taking like a lot of natural herbs and looks quite good versus a handful of pills or needles, oh, I'd take the herbs and vitamins anyway. But do they work? No, there's not a lot of good evidence for that.
Data to support, analytical data to support that.
So evidence should be treatment should be evidence based. If you're you have to prove that you're doing good, and you have to above all do no harm. That's so important for anything. So in the last almost 20 years, how many medicines do you think we have out there to treat dementia? This blew my mind.
7.
I wish it were at least 7. We've got 3, really. All right, Aricept, Razidine, Namenda is a different one, came out previously. There's Exelon, and then there's a product that combines the two. So really, four medicines. We've had nothing new in 19 years.
How long does it take, just speaking of getting new medicines, because with COVID they kind of rushed the shots through.
Mm-hmm.
How long does it normally take for approval?
Well, they have to do typically phase 1, phase 2, and phase 3 trials, for each of these. The phase 3 trials are safety studies just to make sure people don't have any symptoms. The other ones tend to be dosing studies and overall safety studies as well. It could take anywhere from 5 to 10 years to bring a medicine to market. Average medicine brought to market costs $1 billion, but only 1 out of 200 medications ever make it to market. 1 out of 200 ever make it to market. $1 billion. So for every one medication, we're probably, the drug companies, the research trials, research agencies are probably dropping about $200 billion to bring one medication to market.
Probably half of that for the ones that fail.
Yeah, well, most of those fail. Most of those medications fail. So one category we have for treating a lot of the dementias, and these are all approved for Alzheimer's disease, are what are called cholinesterase inhibitors. And what they do is they raise acetylcholine levels in the brain. Acetylcholine is a neurotransmitter that kind of jumps between your two neurons, the two nerves in the brain, nerve cells. And we only have 3 categories: Aricept, Exelon, and Razidine. And again, they all work the same way. They prevent the breakdown of acetylcholine, and by doing that, it raises the acetylcholines in the brain, levels in the brain. That may improve, well, not so much improve, but slow the loss of cognition. 6 to 12 months, it may help. It only works for probably about half the people who take it. All right, so the people who take it, if they do show some stability with it, they're not having progressive losses, after about 6 months, it's kind of like the law of diminishing returns. You don't get much bang for your buck. It doesn't work if we keep doubling the medication, because if we increase them, we have more side effects associated with it. Usually GI side effects, nausea, queasiness, vomiting, may have a loss of appetite. Sometimes people have increased frequency of their bowel movements, things like that, GI symptoms. Now, memantidine is another medication. It works differently. It works on a different chemical in the brain called glutamate, and it blocks what's called the NMDA receptor in the brain. And it, like the cholinesterase inhibitors, it may delay worsening for a time. It may delay the illness from getting worse, but it doesn't really cure it. We're treating symptoms more than curing. Because again, the damage is still being done in the brain. We're not fixing that. We're just trying to treat the symptoms more than anything else. That's how these medications work. And the side effects seem to be pretty similar to that of for memantidine as it is for the cholinesterase inhibitors. Mostly headache, dizziness, some constipation, or some other GI symptoms, queasiness associated with it. But again, it's law of diminishing returns. And as I said, these medications work for about half the people who we give them to. The other half may not show a lot of improvement with it at all. And then if we're going to use it, we might get some benefit for 6 to 12 months. But oftentimes, I might not give these medications not just because of their cognitive losses, their memory losses. I might give them these medications because it can reduce the neuropsych symptoms. They may not have the behaviors, as aggressively as before. Now, what's coming down the pike? Well, the FDA recently ran through and approved a monoclonal antibody for this called Aduhelm. And Aduhelm, it seems to work by directed against the beta amyloid plaques within the brain. You give an infusion of this every 4 weeks. You have to give it by vein. This antibody goes up into the brain. It finds the amyloid plaque and basically attacks it, and then uses your immune system to go ahead and reabsorb the plaque from the brain. And there is some evidence to suggest that we do remove the more plaque from the brain, we may slow the losses of the dementia. we're not quite sure. We don't have great evidence yet that it restores cognitive functioning. But as I said, some of these changes in the brain occur 10 to 20 years before what happens. What happens if we give these medications to people before they start getting dementia, before they start having problems with it? Then we might have some impact with that. Those studies haven't been done. But as we talked about, there's no free lunch. There's some evidence that suggests that when we do brain imaging of these people after they get these monoclonal antibodies, they may have these abnormalities within the brain. They might have some increased risk of intracranial bleeding associated with it. Imagine we're taking stuff out of the brain. Could it cause some bleeding? Possibly. And this is the first one that came out, the Aduhelm. There's 2 more that are in the pipeline, donanemab and lecanemab. So hopefully we'll have some more tools in our toolbox in the near future. Now, that's absorbing plaque that's in the brain in the first place. There's a chemotherapy type of medicine. Medicine is developed for cancer called saracatinib, and it basically turns off the protein that causes like a lot of the destruction that occurs with it in the brain in the first place. So yeah, a person might have the amyloid protein deposit in the brain, or those tau tangles, or that alpha-synuclein deposit, the PIX bodies put in the brain, but this may reduce the inflammatory response that takes place around that. And by doing that, we might be able to reverse some of the memory loss that has occurred. So that's, again, a pipeline-driven medication. And then there's a whole new category, too, of something called production blockers. We know that for amyloid to be produced, it needs to be a couple different things that are, a couple different proteins that are acted upon by a couple enzymes, one called beta and gamma secretase. And if you can block these enzymes, then the amyloid can't really form in the first place. It won't get deposited in the brain, and then that might help us out. So again, just a lot of pipeline stuff. Interestingly, we're knowing too that there's a lot of connection between your gut and your brain, that what you eat does affect your increased risk for Alzheimer's down disease or any of the dementias down the road. We know that certain foods will raise your insulin levels in your blood, like for instance, a lot of carbohydrates. We see a lot of stuff going on now about like ketogenic diets, primal diets, lower carb, higher fat diets across the brain. They seem to have an anti-inflammatory advantage to it. They've not really been well studied for this, but we know that the bacteria in your gut is affected by what you eat. The bacteria in your gut also has chemical messaging that goes back and forth between your brain. The gut-head-brain connection, gut-to-gut-head-brain connection. It's pretty interesting. So even lifestyle changes, and boy, we're going to talk about this later on as well, but with the continuing segment of this, but exercise. Tremendous improvement as far as helping out with reducing a person's chance for dementia. Wonderful, wonderful data about that. We've got our Silver Sneakers program. We're going to talk a little bit about trying to get the seniors engaged. Any amount of exercise seems to help to some degree. Any amount of exercise seems to help. There might even be a dementia vaccine coming down the pike, where it's not the kind that you get the shot. It's like a nasal spray that you might get. It's called Protalin, and it stimulates the immune system. And when it does, it prompts the white blood cells in your neck to migrate up to the brain, and it seems to clear the beta amyloid plaque out of the brain. So a vaccine for dementia. Isn't that curious?
That would be great.
Great, it'd be amazing.
Sign me up for a test trial.
Yeah. I'll take it in suppository form.
All right.
Yeah. All right.
I'm not going that far.
But again, with a lot of these treatments, again, it seems to be we get less bang for a buck. If you start a person on it, you keep increasing the dose. After as well, you don't get as much much return on the dosing. And
let me ask you about, since you talk about treatments, a lot of athletes, not now, but injecting themselves with human growth hormone.
Growth hormone.
Does that help anything?
With dementia, it does not seem to.
Okay.
It seems to maintain muscle mass. It seems to maintain vitality as far as growth hormone, but oh my gosh, it's so stinking expensive, incredibly expensive. It's not really FDA approved for that either, but
okay.
A lot of people use it off label. And it's interesting too, if you stop a lot of these medications for Alzheimer's and you restart them, you might not get back to where they were before. So usually when folks start on these medications, they may be on for keeps, even though you're not getting much bang for your buck. But again, all these treatments have not been shown to cure dementias. They've been shown to treat it, slow the losses. Not prevent, slow the losses. Now, as we mentioned, a lot of folks will have a lot of neuropsych symptoms, depression, anxiety. They might have hallucinations and delusional thinking. So I'll use those medications. Again, if I have a patient without dementia, I'll use those medications if it's disturbing enough to interfere with a person's lifestyle. But it's a trade-off. No medicine is a free lunch. All medicines have side effects, and you've got to use them very, very judiciously. For the antidepressants, typically drugs like Celexa, Prozac, Paxil, Zoloft, you may have heard a lot of those, Remeron or Cymbalta, we'll tend to use a lot of those medications. Mirtazapine, Remeron, if I have a patient with dementia and they're losing a lot of body weight, or they're having like day-night reversal, I'll use that medication at bedtime because it fires up their appetite. It increases their sleep, makes them sleep better. So if they sleep better at night, they may be a little more energetic during the day. Duloxetine, Cymbalta, it's a great antidepressant medication, but in a lot of my apathetic dementia patients, I'll give them that because it'll fire them up. I'll dose that in the morning. It gives them a little bit more zip and zing. It's also approved by the FDA to treat chronic pain. So musculoskeletal pain, arthritic pain, neuropathic pain like after diabetes or shingles, it might help them out a little bit as well. So we choose and pick side effects of the different antidepressants depending on what I'm treating. The anxiolytic medications are folks who are really anxious or jittery or nervous. I don't like to use these too much in dementia patients. That'd be like Ativan, Xanax, you may have heard of, because they tend to make cognition worse. It makes thinking a little worse. It's great for treating the symptoms, but it's treating the symptoms and not necessarily the cause. So if I have a patient with who's like a lot of anxiety issues, I might try them on an antidepressant like trazodone. Makes you a little bit sleepy, help the appetite, smooths you out a little bit more too, some of the behaviors. Where these medications can be used, also the anxiolytic medications, more in a crisis, disruptive behavior. If they're really restless, they're uncomfortable, they're suffering, then I'll use those medications. But they're associated with cognitive issues being a little worse, increased risk for falls, so judiciously. Then there's the antipsychotic medications. These are medicines like Abilify, Haldol, Seroquel, Zyprexa. They're great for treating like a lot of the hallucinosis, the hallucinations, the delusional thinking. Again, I tend to want to reserve these only for patients who are really truly suffering, if they're really, really problems. We don't want to give people chemical restraints. We don't want to sedate them into submission. I still want people to be able to enjoy their lives and enjoy that, but there's no free lunch. All the medications, they have side effects. They have to be used judiciously. The antipsychotic medications, they have some risks associated with them too. The FDA has a black box on them that especially if they're not approved for treating dementia. But will I occasionally use them? Absolutely, because if I have a patient who's really suffering, then I will use those medications in that capacity. Just going through there's a couple of things on the antipsychotic medications, but again, the treatment of the neuropsych symptoms, it's often reactive. It's not proactive. We're always, person shows up with a bad symptom, we have to do something now about it. It's a crisis all of a sudden. We really need to be a little bit more forward-thinking, looking at the patient as a whole and finding out what's causing this decompensation. Why is the patient getting worse in the first place? Are they depressed? Do they have an underlying smoldering urinary tract infection? I've seen patients have a lot of neuropsych symptoms when they're having a heart attack. And that's how they present. No chest pain, no palpitations, no heart flip-flopping in their chest or shortness of breath. They show up with worsening dementia. It's very, very common with infections, especially urinary tract infections. So, again, we talked about this. No free lunch. But there's a lot of non-pharmacological treatments, as well. We don't have to resort to a pill. Pills are easy to prescribe. They're quick and easy. You can write this and hopefully you get the best result. But more often than not, there's a lot of different things that can be done, not only for the patient, but for the caregiver to go ahead and help out. There's a lot of techniques that have been shown to decrease the behavioral signs and symptoms, increase caregiver satisfaction, reduce medication use, and a lot of these treatments can be done by anybody. We talked about exercise, for instance. That's huge. But sensory issues, like there's aromatherapy, music therapy, pet therapy, distraction therapy, a lot of these different things that can be done to massage, warm touch, exercise, a lot of different things that can be done to go ahead and decelerate a patient.
What about, I'm going back to something Pat Summit, you may remember, had early onset dementia, I'm not sure what type. And she said she was doing a lot of crossword puzzles and word searches to keep.
Sure. Like I said, distraction therapy. If a person's like really revved up, like, where are my shoes? Where are my shoes? Well, how are you doing, Bob? What did you have for breakfast today? Distract them from the behavior. There's one thing called DICE, which is tailored interventions. It's tailored specifically for the patient's need. What accelerates them? What can we do to treat the underlying problems? A lot of preschooler teachers do this. We'll do things like look at the antecedent behavior, look at the behavior itself, look at the consequences of the behavior. What can we do to shape that, to treat that, to manage that? Again, requires no medication, but they tend to be much more labor intensive. That's the only downside with it. And then, we've got to think also, what are we doing to support the caregiver? Caregivers, as I said, 2/3 of them are women. 1/3 of them are over 65 themselves. They may have their own health issues. We've got to be better for doing our job at supporting them, counseling them, giving them education, getting them a break, getting a person out of there just to charge their batteries for a little bit, and then training them on behavior-specific endeavors that we could do, things that we could do to go ahead and decelerate a situation. But we got to take care of the caregiver because they're the ones. There's an author named Judy London. She said, caregivers are the ones that have the suffering that we don't see. That's huge. But a lot of these different techniques, they can be done together with medication if necessary. So that's all I've really got to share with you there. I know we're going to use this as a segue to talk about some of the things that Bethel Park has that they can do. But I just wanted to offer that today to our viewers.
Renee Bishop has been a fitness instructor at the Bethel Park Community Center for 16 years. She is currently teaching many Silver Sneaker classes at the center. Her passion and joy shows the continuing growth of students and classes. Her story of becoming a fitness instructor is a personal one of fighting the effects of rheumatoid arthritis. Her focus is on building mind-to-muscle communication, strengthening bones and muscle while protecting joints.
Hi, my name's Renee Bishop. I'm a fitness instructor at the Bethel Park Community Center. I specialize in their Silver Sneaker program. I'm here today to talk to you about the Silver Sneaker program itself. You can stop at the Community Center to see if you're an eligible member, or you can go online and check for yourself. The program is offered through most health insurances, which people don't know. You want to make sure that you always check your insurance when it comes re-enrollment time, because some programs drop the program itself. So Silver Sneakers is an add-on and sometimes is included. So you can check at the front desk at the Bethel Park Community Center. We currently are running 15 classes, at least one per day, and we're here to talk about what benefits the Silver Sneaker classes have for you. We have different types and different levels. If you look at this class schedule that we're currently offering, you'll see just Silver Sneaker classes in the titles. If it has the word boom in front of the title, then that means that it's an elevated class and that it's a little bit harder. Now, our instructors will be able to adapt all classes no matter what your fitness level is. But there is a misconception that because it's a Silver Sneaker class, that it's just going to be with chairs and you're going to sit most of the time, and that's not the case. For me personally, when I put a program together, I'm trying to specialize a lot of the movements to protect the joints as we build muscles. One thing we're going to talk about today is how beneficial the programs are for our mind. We have to keep the connection between our mind and muscle very strong. As we get older, that signal starts to get softer and softer, and it's not doesn't get to the muscle as loud as it needs to. That's when we start getting into we think we're saying, our brain is telling our muscles to pick up the feet, but then we have some fall issues because the signal's not getting there and we're not picking the feet up. Well, it's one of the things we try to keep strong in our classes. So we might do memorization drills, follow along drills. Sometimes it's a matter of tempo drills. But we want to keep that mind sending those signals to the large muscles so we keep that connection strong. A lot of times we think about just building muscles. We're in class just to do that, and that's not the case. All the Silver Sneaker programs are meant to work on muscles, balance, but mostly connection with mind. So we do have a lot to offer for that. So please come and check out what classes we have. For me personally, I've been a Silver Sneaker instructor for 8 years now. I've been teaching at the Bethel Park Community Center for 16, but I've been a fitness instructor for 18. I've seen the benefits in all my students, no matter what your age is. So you can benefit no matter where you start, whether your fitness level's low, if you're older, if you're younger, you have to start somewhere. So don't be afraid to come and join one of the classes. If you have any questions, you can reach out to the center, and they can even give you my email for a connection with myself. All the levels start at a lower, and then we try to gradually build you up, bringing the fitness level to the top tier that we can for individuals. And again, we can all work with whatever level you start at. I think that if you are interested in Silver Sneakers, you can even look up some of the descriptions online. And again, you can always come over to the center. So thank you, and I hope that I can see you in class.
I'd like to thank our two guests, Dr. Kim Campbell and Renee Bishop, for sharing their valuable information with us. We hope you check back with us soon for another great Live Well presentation. In the meantime, I'm Chuck Stover asking you to get up, get out, and live well, Bethel Park.